Hello, how's everybody?
Good, and you?
We'll get started in just a couple minutes. All right, so we will go ahead and get started. Leona, you want to turn your camera on? All right, so this is for exam two. I've shared my screen. We have the concepts guide. So the exam two will cover chapter or cover weeks. Can't even talk. 3 to 5. So chapters 4, 8, 10, 24, 25, 26, 29, and 30, and then 32. So there will be 50 questions on the exam, consisting of multiple choice, select all that apply. You will have math questions on your exam. You do have a time limit of 75 minutes, which is standard unless you have accommodations. So general questions to review, math, IV calculations, determining equivalence and converting between the systems of measurements, oral and parenteral medications, medication dosages for children. So review your math handouts, your practice questions. Always recommend doing extra or additional NCLEX questions in areas that you score weak in, whether it's the nursing process or med surge diseases when we apply those to a community setting. Case study application of concepts, assessment and prioritization, levels of prevention and management of care. Always remember safety first. What is priority? Your prevention level is related to each chapter and the nursing process. Levels of prevention, your Healthy People 2030 objectives. Make sure you go through those. Look at the tables that are in the chapters. Listen to your pre-recorded lectures as well as reading the chapters and taking notes. And then remember that questions come from simulation, homework, handouts. And so you have everything you need. Just take a deep breath and go through the test. So the first part of your study guide, oops, need to move that out of your way. Rural health and migrant healthcare and cultural considerations. So reviewing the consequences of poverty in rural areas. Rural areas are those areas that have, I forgot what I was going to say. I gotta find my notes. Sorry. Communities that have fewer than 20,000 residents, or fewer than 99 persons per square mile. When we look at some of the issues in those rural areas, they tend to have higher poverty rates, lower health literacy levels. They may have as well as linguistic and educational disparities, limited, affordable, reliable, or public transportation, unpredictable work hours, or unemployment. So think of like your farmers, right? They may be really busy during certain parts of the year, not so busy during other parts of the year. Lower population densities for program, economies of scale, availability of resources, lack of access to healthy foods and physical activity options. So think about, where a person lives versus the city versus the rural area. Going to a doctor, going to the hospital, having access to resources might be a lot further away. They may have more limited access to some of those specialties, right? Anybody live in a rural area? So I grew up in Brooklyn, New York, right? Everything is pretty much right where you need it. When I went to high school, I lived in a town called Lake Hopatcong, New Jersey, which was literally the middle of nowhere coming from a big city. And so, where I was used to public transportation, if I needed, if my mom needed to send me to the grocery store, it was literally on the corner. In Lake Hopatcong, New Jersey, there was no public transportation. Back then, when I first moved there, they didn't even have taxis. So you couldn't even like call a cab or car service. We called car service in Brooklyn. Even the availability of the doctors. We would have to drive like 30 minutes just to get to the doctor's office. The hospital was a small rural hospital. And while it did have most of the resources that, most people needed, some of the, more trauma type cases had to travel even further. So these are some things that we have to look at. When we look at health behaviors, living in the rural areas, they might be a little less compliant with, wearing helmets, wearing seat belts, different types of, safety equipment, access to grocery stores. And that could even be in some of your lower economic areas as well. The distance to grocery stores may be a little bit further, and with that lack of transportation, right, it makes access to fresh fruits and vegetables, more healthy foods, a little bit less easy. With the groups that are higher at risk: children, minority, racial, and ethnic groups, single parent families, children. Children, they may also work on the farms with their parents, right? So they may be exposed to excessive amounts of noise, organic and inorganic dust, as well as the hazards of working with farm equipment, right? Because they learn, by watching their parents. And if their parents aren't wearing that protective equipment, then they're not going to wear that protective equipment. They also can be victims of injuries from the equipment that they're using, in even working with some of the tools with some of the animals that are on the farms. And so that when you're looking at that population, the school nurse in that area, they may have an increased role to working with those kids and providing additional resources. They also may be prone to, excessive heat exposure. So looking at some of the heat related injuries that can occur. When we look at the racial minority groups, the Hispanic rate has increased the most. And so working with the Hispanic population, majority of migrant farm workers are of Mexican descent. And so, although there are certain health beliefs and practices that have been identified within the Mexican culture, we have to remember that the beliefs and practices differ among regions and localities within the country, and among individuals. For the most parts, again, their beliefs are going to vary, but they do prefer polite, non-confrontational relationships, right? They like that small talk. And they get, the kind of, little bit of banter back and forth, but more of, a comfortable relationship with the nurse. Nurses are considered authority figures. Women in the Hispanic culture generally are the caretakers, while the men are the ones that are out working. What else about? They looking at insurance rates as well. Remember, those in the rural areas may also have decreased amount or decreased availability of health insurance. They don't always have the occupational health or other things that are offered in bigger companies. So that can, decrease the availability of care as well. When we look at the physical demands, think of the physical demands of the population. Harvesting crops 12 to 14 hours a day takes a toll on their body. So back and neck pain are the most common types of chronic pain associated with many workers. We also have to look at exposure to pesticides. When we're looking at the migrant workers, they generally too will have poor living environments. That pesticide exposure, what do you think is a good primary prevention for dealing with pesticides?
PPE,
PP.
washing hands.
Okay. So yes, your primary would be your PPE, how to protect themselves against, working with those pesticides. What about secondary?
Would that be screenings?
Yeah, secondary is actually washing their hands because they've avoided the primary of preventing exposure. So secondary would be more like your hand washing as well as screening for exposure. And then tertiary. What would be tertiary?
Treating.
Right. Once they start showing some of those signs and symptoms of pesticide exposure, right? The nausea, the vomiting, the skin irritation, right? Tertiary prevention would be the treatment of that pesticide exposure. Language barriers often are an issue too. So making sure that there's access to translators. They also may not have legal immigration status, which would delay them in seeking healthcare as well, because of that status. I covered talk about transportation, talked about that, cultural considerations. When we look at, the vulnerable populations and health considerations under Healthy People 2030, families with children are the fastest growing segment of the homeless population. And so, these are people that are, they're homeless. They may be living in the streets. They may be living in their cars. And how does being homeless affect your health? You're exposed to the elements, you're exposed to disease, you're less likely to have access to healthcare. And, think about, parents that are out there and they're homeless with their children, some of the fears of being discovered, right, may lead to separation from their children. when we're looking at vulnerable populations and HIV, how is we talked, HIV is a med surge concept. So tell me a little bit about what you know about HIV.
They're gonna be able to get their medications
Say
or
that one more time.
needles.
I didn't hear you. I'm sorry.
They won't be able to get their medications if they're homeless, or needles, or the care they need.
Okay. So what are some primary prevention that we can do for HIV? So let's say that we know that there's vulnerable populations for HIV, right? There are high risk people like your homeless population, your IV drug users, those that have multiple sex partners, right? Those are some of your high risk. What are some primary prevention measures that we can do to prevent HIV?
Sex education, clean
Sex
needles,
education, clean
clean
needles.
needles.
Mm-hmm. Right? Doing the education before they're exposed. The sex education, the barrier methods of protection, limiting sex partners. When we look at like your HIV drug users, clean needles. Um, in some areas, and this was a while ago, there's some areas that will still do needle exchange programs. But think about your public health, maybe teaching them how to clean their needles, right? If we can't prevent them from using, how do they try, how can we try to teach them to be safe? What are some secondary preventions for HIV?
That will be the screenings, right?
Right, the testing, the screening for HIV, absolutely. And then, of course, your tertiary would be
Treating.
their treatment. I saw that look, Leanna. Right. So that is your treatment. Your tertiary is your treatment. Very good. Homeless adolescents living on the street also are exhibiting greater risk taking behaviors, right? So they generally will have an earlier onset of sexual activity. So they also too are at a greater risk of contracting AIDS as well as hepatitis B. So this population is especially at risk as well. Other risks, you're pregnant, your single motherhood is increasing. What are some risks associated with being a single mom?
RS.
Well, so depending on where you are is going to determine the availability of resources, right? The younger they are, the more likely they are to have less access to healthcare. They're at an increased risk for poor outcomes, right? So look at our adolescent females, right? They're more likely to deliver the more low birth weight babies, right? They're more likely to deliver before 37 weeks. And those low birth weight babies are a greater risk within that first year. And so, we look at some of the risks with our teen moms, teen pregnancies, and we'll talk more about the teen pregnancies, but thinking of, sorry, my dog started barking. there are reproductive health services that are available to teens, whether it's through Planned Parenthood or even through some of their healthcare providers. So I know when I worked in primary care, if I had an adolescent, if, whether it was male or female, didn't matter if they were discussing a topic regarding to reproductive health, and sex, that is a confidential topic. Providers, will keep that confidential from parents so they can get birth control, especially if they're, sexually active. So it is confidential care. Other things that we worry about with teen pregnancy is nutrition, right? That's a really difficult time for a female adolescent, right? We're in puberty, we're in high school, we're pregnant. They have to understand that they have an increased caloric requirement so that they can meet the growth and development needs for themselves, as well for for adequate fetal growth. And sometimes, they don't want to gain that weight when they're pregnant. As well as, what's the average eating habit of a teenager anyway, right? Get pizza and fast food. They want to hang out with their friends, so their choices may not always be the best when it comes to eating. So, education about proper diet, encouraging them to, go to their doctor's appointments. Regardless, teen pregnancy is always going to be considered high risk. They also may put their, we need to provide education about, how to take care of an infant, right? It's not innate on how to take care of a child, especially when you're a teenager, right? Even as adults. I mean, I remember having my first kid, and, being completely unsure of myself, and not knowing if I was doing the right thing for my child. So, education, parenting classes, and then school and education. How many of our teen parents or teen moms are able to complete high school? So assisting them in completing high school, whether it's getting their GED, or, actually graduating, with their high school class. We know that, not having an education increases the rate for poverty. So we want them to get their education, so that increases their chances of finding something better, for them and their child as they grow older. Does that make sense? And then when we look at alcohol, tobacco, and all of those other products, so we want to look at the healthy people for 2030. So the goals for healthy people 2030 for alcohol, tobacco, and drugs is to increase the proportion. One of the goals is to increase the proportion of people with substance use disorder who get treatment. We want to reduce the proportion of people who had opioid use disorder, and then increase the Medicaid coverage of evidence-based treatment to help people quit tobacco. And so alcohol, tobacco, and other drugs are the leading national health problem right now. They cause more deaths, illness, and disabilities than any other health problem that we have. And there's a variety of different drugs out there, right? You have stimulants, you have depressants, your, illicit drugs, your legal drugs like marijuana. Although tobacco and alcohol are legal, doesn't necessarily mean that they are safe to use, right? And that's why we have the Surgeon General warnings in order to help deter people from starting to use these products. What's the difference between psychological and physiological dependence?
Psychological is like a mental,
Right.
and then the other one is like your health depends on it. You can't stop it, or you will die if you potentially stop doing it.
Right. So the psychological dependence can occur with any medication. And you're right, it's a psychological craving for the medication. They have feelings of satisfaction as well as the desire to repeat the drug, just to avoid, the discomfort that occurs if they don't have it. Whereas the physiologic dependence, that is, if they don't get it, they will actually have physical symptoms, physical signs, that can be extremely dangerous, when they don't have access, to that drug or that stimulant. And so, all of whether it's a vape, whether it's a cigarette, they all have unsafe chemicals that are part of the mixture that they put in there, right? Cigarettes is not just tobacco, right? It is a bunch of chemicals, it's paper. And so they're not just inhaling the tobacco and the nicotine, they're inhaling the, other chemicals that are in there. Same thing with vaping. I think initially when vaping first, became more popular, they thought that it was a lot safer than smoking cigarettes. But they still have a bunch of other chemicals. There's still a lot of issues that can occur, when we're looking at those vapes. And so when we look at the primary, the secondary, and the tertiary prevention for your alcohol and drug problems, primary is looking at, we're promoting more healthy lifestyles, more resiliency. So how do we get people, because the best way to prevent smoking is to not have them start, I guess would be a good way to say it, right? They won't have to go through the withdrawals, and all that stuff if they don't ever start. So, promoting that healthy lifestyle, avoiding the smoking, avoiding the vaping, avoiding those other drugs, as well as educating on the guidelines. We know that there's lots of medications out there, that are used for a variety of different ways. And so, just because they are used, I'll use marijuana, for example. Yes, I know marijuana is legal, right? The states have legalized it, but prior to that, right, what did we use marijuana for? Anybody know?
Glaucoma and cancer, all type of stuff.
Right. We use that for glaucoma, to help decrease the intraocular pressure. What about cancer do we use it for?
I don't know. I just
It's okay. So it's used as an appetite stimulant. Okay. What do they say? When you smoke marijuana, you get the munchies, right? And so, we still use like the pill form is called Marinol. It comes in a pill form, and we still use it as appetite stimulant in certain populations. So it's a little bit different, right? But we still do use it. And there's other, the cachexia, in some way, they say in some cases, the marijuana helps with some of the nausea associated with some of the disorders as well, like chemotherapy, drugs, that kind of thing. But again, primary prevention, right? We want to teach them to lead those healthy lifestyles. Secondary prevention for drugs and alcohol, that would be like early detection programs in school and other areas, just to determine the presence of the substance abuse. And then tertiary, those are the programs to help people reduce or end substance abuse, right? In some cases, they may have to go into a treatment program, right? Think of your more heavy drugs like your heroin, your cocaine, your crack. They don't have inpatient for nicotine users, right? Or even caffeine. How many of us, drink a lot of caffeine during the day, whether it's coffee or infuse, energy drinks, that kind of thing. Caffeine's a drug. It can still have negative effects on your body as well. It's just looking at healthy lifestyles when we're dealing with alcohol, tobacco, and drugs. It needs to be treated like it's a disease process. We have to be non-judgmental when we are working with this population, and you're going to see this no matter what aspect of nursing that you choose to go, whether it's in ER, whether it's in the med surg, even in long-term care. This sounds horrible. I was working at a long-term care facility in Texas. And we actually had to, I don't know what the word was, I guess discharge, but like not by choice. Because we caught one of our residents smoking crack in the bathroom and actually invited another resident to do it as well, which puts obviously both of them in danger as well as other members within the facility. I've also had, we had I'm trying to remember if it was before the legalization or after, and I cannot remember, had an MS resident who would, he had a motorized scooter, and he would literally scoot himself off the property and he would smoke his marijuana, and then come back into the facility. These are dangers, and it sounds silly in a sense, but it's like, think about it, driving under the influence, right? He is operating a motorized wheelchair. What if he fell off a curb? What if something happened to him while he was doing that? And so we have to assess these dangers because they do happen. When we look at how do we deal with a patient in alcohol withdrawal, they do, it needs to be strict medical supervision when they are withdrawing so that we can make sure that they are they are safe, and that we are, monitoring them, and, providing medical as well as pharmaceutical, treatment while they are, withdrawing from whatever it is that they are withdrawing. The best way to withdraw from something is to wean it off, right? Is to gradually reduce the dosage, the frequency. That's usually the safest way to get somebody down, whether it's off a medication, a drug, or even alcohol. In some cases, we don't have that opportunity, right? They have a car accident, they have a trauma, they have a heart attack, and they come into the emergency room, and it's going to be a not so much of a gradual withdrawal as such as an immediate withdrawal. So we do have to be very careful with that population. Some of the CDC guidelines for dealing with alcohol, tobacco, and other drugs. The big thing is we want to try to prevent the young people from starting. We want to promote quitting. We also want to reduce exposure to secondhand smoke, as well as identify and eliminate tobacco-related health disparities. So think about that secondhand smoke. There's people that are diagnosed with lung cancer and other cancers associated with tobacco and nicotine that have never smoked, but they have been exposed periodically throughout their lives. So whether it's, parents or friends, that smoke around them. I know here in Virginia, I don't know about other states, but like you can't smoke in the car with a child in the car. It's illegal. I don't know if they actually like enforce it, if it's one of those, how there's some laws like you can get pulled over for doing certain things, but you can't get pulled over unless yeah. So I don't know if it's one of those like if they can pull you over for that and give you a ticket. But it is illegal. And I think it's 16. I have to look up the law again. I don't have little kids. I have grandkids, but I don't very, very rarely do I have them in my car, but it's one of the laws that I do have to look at. And then when we look at, the faith community nurse or the faith community nurse, the home health and the hospice nurse, the faith community nurse, those are we're dealing with individuals, families, as well as members of the faith community. It is a very holistic approach. The congregational faith community nurse serves the congregation in the community. The roles may change a little bit depending on where they're working, and it could be across different religions, right? You have your Catholics, you have your Jewish population, your Muslim. So it could be across any of those. They do, as a faith community nurse, you do need to be aware of the faith and the belief practices of the congregation themselves. Usually, if you want to, be a parish nurse or a nurse in that faith community, usually they are a member of the same religious sect. And so they're going to pursue, perform the services, in conjunction with, whoever the pastor, the minister, the priest, rabbi, whoever, as well as other healthcare members, and volunteers, to provide that holistic approach, the body, the mind, the spirit. And so, they can do health education, whether it's health education at the church in a more formal setting, or even going into, patients or members of the congregation's home, and provide resources there as well. There's also, that spiritual approach. So they also may help to identify, the spiritual needs of the population, and address those as well. When we look at government and law and policy activism, one of the biggest things that we can do as, nurses, and this is something that, I remember always learning about in nursing school, 25 plus years ago, is we need to be aware of the impact of the governmental law and health policy on nursing, on health, and on communities. They, said in, the government makes laws and provides for guidance that, will affect us in healthcare. And so like, I don't know, a lot of us, if you follow the news or if you look at any of like the nursing organizations and stuff, what's one of the biggest things that nurses advocate for? What's, and do you guys work in healthcare at all?
Yes.
Okay. So what do you think one of the biggest issues that nurses face?
Shortages. I mean, no help.
Okay, shortages. That's a really good one.
Oh yeah. Hmm.
What about nurse patient ratios?
You said nurse patient ratios?
Hmm. How many patients do you have to take care in a shift?
Yeah.
So hospitals have it a little bit different, right? Usually it's, 4 to 6 patients per nurse. I've seen it go 4 to 8, depending on where the unit is. But think of the nurses in long-term care. Nurses in long-term care can go 30 patients to one. And that's a lot. That's a lot. I was having this conversation with one of the director of nurses just a little late, just last week. Um, And so the average is 30 to 1. So we have a 60-bed facility. We have 2 med carts. So, each one of those med carts is delivering medications to 30 patients. On average, there's only 2 nurses. And so because of staffing, right, we don't always have that third nurse that's available to help, do treatments, answer the phone, get orders, all of that. And so it puts a big strain on nurses, right? Are we able to really perform like we need to perform in those situations? My daughter, when she first started, I don't remember when she graduated. She's been a nurse probably for, probably about 7 years now, I think, maybe 8. She started as on a med surg unit. And when she first started on the unit, it was a tele unit. And so the average was 4 patients. And then they wanted to change the name of the unit to a med surg unit to give them 6 to 8 patients. But they didn't take the tele away. So it was still tele under a med surg name. So how are they supposed to monitor 6 to 8 patients that are on EKGs and still affect and then catch things that need to be caught to prevent further injury, right? So when we look at advocating, it's not just for ourselves, it's for patient care as well. What are the things that we can advocate to make a difference? Or what is the government, what laws are the government passing that could potentially have an effect on us as healthcare providers, right? And so, maintaining and, keeping up to date and knowing what is going on is really important. So I always say, I always advocate, join the, Student Nurses Association, the American Nurses Association, all of those things that just helps you to kind of understand. The government also is the one that set up the Healthy People. So we started the Healthy People Initiative back in the 90s. We started with Healthy People 20 or Healthy People 2000. Then we did Healthy People 2010, 2020, and now we are on Healthy People 2030. A lot of the similar goals, we haven't met, we've kind of just expanded on the goals for the healthy people in order to, increase the health of the people here in the United States. What's the World Health Organization?
That put regulations on vaccines and, medications.
Okay. So the World Health Organization, it's worldwide. So it doesn't work here just in the United States, but with members, with other countries to promote health efforts. It also helps to collaborate help, efforts between the countries, as well as, to disseminate information. across the countries as well. And so the World Health Organization provides an amazing amount of information, as does the Centers for Disease Control and Prevention. I love the CDC. The CDC is an awesome thing. You can go to the CDC website and find information about just about anything. When we look at nursing itself and what governs nursing, so we do have the state boards of nursing. So every state has an individual state board of nursing. That state board of nursing pretty much it produces, those nurse practice acts, which give us what our scope of practice is. According to what level of nursing or whatever the board covers in each state. And you can go to the Board of Nursing in your state and you can look at what the board and, which licenses the Board of Nursing does regulate, and find your scope of practice. The scope of practice that is produced by the boards of nursing are there to protect the public, so that, we're only doing things that we have been trained to do. And even with the, what are they called? The compact license, right? The compact states, where you can practice from across state lines into another state. You still have to make sure that you know what that Nurse Practice Act is within the state that you are working in. So, like if I were to go work in North Carolina, if I were to go back to Texas, I have to keep myself up to date on what each state's Nurse Practice Act is, so that you don't violate, because not knowing is not a good enough answer when it comes to that. When we look at negligence, or malpractice, that's an act or a failure to act that leads to injury of a client. To recover damages in a malpractice act, the client must prove that the nurse owed a duty to the client and was responsible for the client's care. The duty to act the way a reasonable, prudent nurse would act in the same circumstance was not fulfilled. The failure to act reasonably under the circumstances led to the alleged injuries, and the injuries provided the basis for a monetary claim from the nurse as compensation for the injury. And so you got to be really careful. That's why, knowing what your scope of practice is. If you don't know how to do something, should you do it? No, absolutely not. I would, as an educator, as a healthcare leader, I would rather a nurse say, I'm not doing this because I don't know how to do it, and then, provide the education, the resources, so that they can, get to, be able to do that skill. Because that puts you in an uncomfortable, puts a nurse in an uncomfortable position, and you don't want to cause any harm to patients. So it's always better to say you don't know how to do something. And that is one thing that I will tell you that is really good, is Google or YouTube videos, right? We actually had an issue, I don't remember, I think it was the flu test that we were using. Somebody threw the directions away on how to do the flu test, and it wasn't one I had seen before. And I was like, okay, so I Googled the company, and on the company website, it had the directions on how to do the flu test. A lot of our, like the DME companies, they all produce videos on how to use the equipment. They update those videos on how to use equipment, so that if there are things and, people are using their equipment, that they can always use that as a reference. I have I forget what it's called. It's called an iStem. It's basically like an internal TENS unit. You know what a TENS unit is? Have you guys seen a TENS unit? It's like the little pads you put on and it stimulates the muscles. So I have an internal one. So there's a little piece that goes, it's in my ankle. And then it has an external like piece on it that actually is what causes it stimulates the internal part. And I couldn't remember how to adjust it because there's different levels. And I literally went on YouTube and I put, this is what I have, and, was able to get, learn how to adjust the settings. And so you have to be careful, just like with anything else. But there's lots of resources out there, for people. Excuse me. When we look on Medicare and Medicaid, Medicare and Medicaid are government programs. Medicare is for those that are 65 years old or 65 or older and are disabled. It is the federal insurance program from the Social Security Administration. Medicaid is based on a lack of financial resources. It is federally, but it's assigned to each state. So each state may run their Medicaid program a little bit different. In order to get home health under Medicare, they must have a skilled need for reimbursement. It can't just be an ADL thing. It has to be whether it's I'm trying to think, a wound care, a new medical device, if they're on oxygen, if they have a feeding tube, or even initially IV medications, right? Because we can send people home with IV medications. We can send home patients with trachs, with tube feedings, with all sorts of more, what's the word, complex equipment than we used to in the past. Right? It used to be that if you had to be trached or you were on oxygen or you had a tube feeding, right? You were usually in the hospital, you were in a long-term care facility. Now we're sending people home with these equipments. And that skilled care need, it may only be for a short period of time while the nurse is providing education to either the patient or their caregivers. And then once they feel comfortable, then the family or the caregivers, right, they will take over that need. And so that's, the coverage for home health. Hospice care, what's hospice care?
End of life care.
Right. That's your end of life care. That's the dying with dignity, right? They are going to make sure that that patient is comfortable, and, allows them to die a peaceful death, where they choose, whether it's at home, whether it's in the hospital, whether it's in a long-term care facility, or in some cases, even a hospice house. One thing about hospice is there's no curative treatments, right? We're not providing a cure. We're just providing a comfortable way of life. Palliative care focuses more so on optimizing quality of life. There are curative treatments during palliative care. And then your transitional care, that is the the coordination and the continuation of healthcare as they transfer between different levels of care or even in different locations, right? So a transitional care can be something as simple as I'm going from the ER to the med surg floor, or the ER to the ICU, or the ICU to step down. Or it could be I'm going from the hospital, I'm going into, a skilled rehab center so that I can get, physical and occupational or speech therapy, get my strength back, be able to perform my ADLs before I go home, right? And so what's really important about transitional care is because that there is that transition of care. That's when we also look at their medications, right? Making sure that we're doing medication reconciliation as they're transitioning as well. So nothing is missed or skipped, or omitted, added. And that helps everybody to know, what that patient is, taking. When we look at home health, what are some assessments a home health nurse might do during a home visit?
Environment,
Environment. What about the environment are we worried about?
safety,
Okay, safety. What kind of safety? I'm pulling teeth.
falling hazards, paint,
Mm-hmm.
um, outside, neighborhood,
Mm-hmm. Yeah, right. Because if they're, what do we do if their neighborhood isn't safe, right? Is it safe for them? But safety within the home is especially important, right? Do they have food? Do they have electricity? Do they have hot water or water, period, I should say? You're right, the throw rugs, is the electricity in good repair, right? Is there one electrical outlet that they have, what are those things called? Those little strips, the power strips plugged into, and electrical cords laying all around, what are animals do they have? I have dogs. I've had dogs. I love my dogs. God bless my dogs, but I've also been on crutches. Crutches and dogs, not always a good mix, right? Crutches and cats, not always a good mix, right? Because, especially when you like your dogs, then your dogs like you, they want to be under your feet 24/7, right? And so it could be a trip hazard. And yes, I have tripped over my dogs on crutches and off crutches. So, not saying that they need to get rid of their dogs or their animals, right? But what are some things, that we can put into place? Who's going to do their grocery shopping for them, right? How are we going, if do they live alone? Are they able to cooking for themselves? Or are they, these are all things that as a home health nurse, we need to take into consideration when we're looking at our patients, and, work and being at home. If they do have, caregivers in the house, how well are they able to assist our patient in caring for themselves? So like we had, bless her, oh my gosh, it's so sad. So we had a patient, they were skilled, both of them were skilled. I forget what she fell. She fell, and I'm trying to think, she broke her hip. So she fell and broke her hip, of course, went to the hospital, had surgery, came to us. But less than a day after she fell and she broke her hip, her husband fell as well, and they found him in the home with a head injury. And so they both ended up in the hospital. They both ended up in a rehab, for PTOT, to get their strength back to, go back into their home. And so what's the frailty level of the caregiver, right? So think of some of our older population where we have, elderly couple living together. Maybe they don't have any family or friends in the area and they're trying to take care of themselves, right? What's their access? What about their medications? We think about that population. We think about vulnerable populations, right? We talked about the homeless. We talked about pregnant adolescents. We know that our elderly population is also a vulnerable population. We have, fixed incomes. They may have to make the choice between paying their bills and paying for medication, or paying their bills and buying food or buying medication, right? There's a lot of different dynamics that go in. So that home health nurse really has a lot to do when she goes into those houses. When we look at environmental health and epidemiology, So, you know, epidemiology is the study of health-related trends in populations, for the purpose of disease prevention, health maintenance, as well as health protection. And so nurses, we can use these principles to provide health interventions to targeted groups. And we do have some wonderful epidemiologic calculations that provide information about the impact of disease as well as death on specific populations, as well as, you know, different aggregate populations as well. So the case fatality rate, that is the proportion of persons diagnosed with a particular disorder who die within a specific time period. It is an estimate of the risk for death within that period for a person newly diagnosed with the disease. So how would I explain? So think of, you ever look at statistics regarding certain like certain cancers, or even just other disease processes, right? What the average or the average survival rate is. That is kind of what that means, right? They're diagnosed with a certain disease, and this is how long that they have survived. Persons diagnosed with a particular disease often want to know what their probability of survival is. It isn't an exact science, right? It's usually just, you know, an estimate. And then risk and prevalence. So what is risk? Is risk.
Something that could negative, I can't even say negatively impact something, I guess.
Okay. So, right. So the risk, right? Why and how the disease occurred. Okay. What's the prevalence? The prevalence is the number of existing diseases that we have, like the number of existing cases, that we have at a specific time. So you have this group or this community, this population of people, and then how many within that population have diabetes, heart disease, kidney disease, whatever within that population. So that's the prevalence. And so, you know, we can the whole purpose of the epidemiologist, right, is to monitor the health of the population, understand, you know, what determines health and disease in the community, as well as to investigate and evaluate interventions to help prevent disease and maintain health. And so if we know, okay, there's specific risk factors and there's a specific prevalence of a certain disease within a given area, right, that helps us to target our interventions. Does that make sense? And so, you know, and then other things within epidemiology, of course, you know, we have the epidemiological triangle. And so your epidemiological triangle, that is your host, your agent, and your environment. So any, you know, change in one element of the triangle can influence the occurrence of disease by increasing or decreasing the person's risk for the disease. Again, risk is the probability that the individual will experience an event. And so an agent is us, right? A human. It's, you know, or the host is human. Sorry, I hate when I do that. The agent is the whatever is factor that's present or lacking so that disease can occur. It could be infectious, so it can be bacteria, virus, it can be a parasite, it could be chemical, right? Think of like lead poisoning, mercury poisoning, pesticide poisoning. It could be radiation exposure, hot, cold, right? Think of like your heat stroke, your, oh, I didn't realize we were an hour already. I was just going on. I'll stay on as long as y'all are. So um, then your host, right? That's us. Those, species, a living species capable of being infected or affected by an agent. And of course, there's things like genetics and immune characteristics, right? That make us more susceptible in certain cases. Certain lifestyle factors also, determine our susceptibility, right? And then the environment, that's all the, internal and external influences on either the host or the agent, right? So it could be climate, it could be population, distribution, it could be socioeconomic, it could be working conditions. And when you have that perfect little triangle, that is, kind of what we're looking at when we're talking about, epidemiology and the principles of epidemiology. I'm just checking my notes to make sure. And so we have different kinds of epidemiology. We have descriptive epidemiology, that describes a disease according to the person, the place, the time that it occurred. We have analytic epidemiology that looks at the etiology or the cause, and then deals with the determinants of health and disease. So how did it occur? Why are, some people more affected than others, right? So we had a flu, we didn't have an outbreak. It wasn't really considered an outbreak. But why is it that some people got, some people in the facility got the flu and others didn't get the flu, right? What are the different factors that are involved in that, in that? Or, why is it that, and this has happened to me and my husband, where we've gone out to eat and I've gotten sick off the food. We've had the exact same thing and he didn't get sick. So, right. So what are some, the different factors that, are involved with that? Then we go to our occupational health nurse. Occupational nurse, geez, can't even say occupational health nurse now. Your occupational health nurse, they, are the ones that are working with in organizations to provide healthcare as well as safety programs to workers, worker population, as well as community groups. And so, people that work in like a big, hospital organization, we know that they have occupational health nurses. So they're the ones that are going to do like your yearly assessments, your new hire onboarding, right? Your immunizations, your lab tests, your drug tests, that kind of thing. But the goal for the occupational health nurse is to promote a healthy work environment, to support or to foster the health and safety of the workers. And so we think of healthcare because that's where we are. So like, what are some of the common injuries that we see in healthcare? Back injuries are number one, especially for nurses, right? Usually due to poor body mechanics. And so, but think about, I'm trying to think of what's in my area. Oh, we have the shipyard. Shipyard has occupational health, right? And so they're going to deal with the hazards that they have down at the shipyard, which are tremendous. Because they have heavy equipment, they're on the water, they're dealing with ships, they're dealing with chemicals, paints, all of those things. So, what kind of injuries are more prevalent? And then looking and seeing, what education can we provide, right? Make sure, they're wearing their hearing protection, their eye protection, their hard hats, right? Their steel-toed boots. As nurses, making sure that we're using our equipment appropriately, right? Sharps containers, retractable needles, good body mechanics, all of that. And then OSHA is the Occupational Safety and Health Administration. They're the ones that are going to develop and enforce workplace health regulations to protect the safety and health of workers. They also will provide education to employers about workplace health and safety. So, that's like they will come and do evaluations to make sure that all of the proper procedures and policies are in place, make sure that equipment is functioning that it's supposed to, as well as making sure that people are using the equipment like they should be using the equipment. So, all right, so I apologize, went a little bit over an hour. Does anybody have any questions? Nope. Well, I thank you for coming.